mostly on the lateral aspects of the SI joints and then in the body of the sacrum itself. And you can see the difference here on the left if you just put a short screw versus a transiliac transsacral screw, how much the force is distributed, and you have a much more stable fixation. Cannulated screw techniques. So on the left, you can see an anterior column or a ramus screw that's being put antegrade. These are obviously done under fluoroscopy, so you have to have a really good understanding of the anatomy of the pelvis. It's a very three-dimensional structure, and you have to have a very good radiology technologist to help you, and you have to have a lot of patience as well. On the right side, you can see the corridor for the posterior fixation. Always remember your dysmorphic sacral patients. In some of them, you cannot really put a transiliac transsacral screw through S1, so you have to rely on S2. In fact, S1 is only available in about 50 to 55% of patients, so it's actually quite more common than we think it is. And now what about acetabulum fractures? Similar to the pelvic ones, the patterns here are different than your regular car accident ones, so they're mostly anterior column posterior hemitransverse or your ABC type fractures. These fractures are highly associated with marginal impaction, so look out for your gull wing sign on your scan or your x-rays. A lot of these, you have the quadrilateral plate, which is destroyed and smashed. You have medialization of your femoral head, and you have pre-existing OA. And the goals here are similar to the pelvis fracture fixation. So you really want early mobilization, and you want these patients to get up and going to decrease the amount of complications as much as possible. And this is a nice figure because it really shows, like, as a normal person, if you look like a basketball, you can bounce really well. While if you're a deflated one, it's really tough to come back. So again, the options here are conservative. You can go with ORIF, you can go with ORIF with a total hip at the same time, so you do it acutely, or you can do a delayed THA. There's lots of literature about this, lots of debate, but I would say the take-home message from this is acute THA has the highest readmission risks and immediate post-op complications, but on the long term, it's the one that has the best results. While delayed THA actually has worse outcomes and compared to acute. And I think that really has to do with the fact that we still have a divide between trauma surgeons and arthroplasty surgeons. There is not a lot of trauma surgeons do arthroplasty, and not a lot of arthroplasty surgeons do trauma. This is probably why you have a lot of immediate post-op complications with these. But there's a new concept coming up of traumaplasty, where some of these fellowships are exposing the fellows to both, so you can have a good grasp on all of these techniques involved. So in summary, the stable injuries can be treated non-surgically. Make sure your posterior pelvis is nice and stable. If you're not sure, you can always proceed with an examination under anesthesia. Sometimes even the type 2s that look stable, the patients have still lots of pain and discomfort, and for these ones, I personally fix them with a couple of screws and they do much better. Percutaneous techniques as much as possible. Remember, you're working with poor bone quality. You're not working with 20-year-olds. And ORIF combined with THA seems to be the way to go. And if you're not comfortable doing these, always ask a colleague in your hospital or try to transfer them somewhere else where you can help the patient. Thank you.
Well, Abdullah, thank you very much for this presentation. First, any question from the audience? Don't be shy. Alain, again? خي أهلك فاز bien منيح.
Thanks for the presentation. In this kind of population, do you advise adding some cement with the screws? Because if you go for percutaneous technique and they have osteoporotic bone, sometimes even in that case, if you want to put them on a fully load bearing after the operation, we might need some help or assistance. What is your experience with the cement?
I don't have a lot of experience with cement because the pathways are actually very small. So in order, for example, to put a screw in the pubic ramus, you have, like, it's really tight and really small, so I don't even see a place there to put cement in it. But what I would say, some of the newer implants, which are curved, then These ones, you can purchase more bone with them. So if you don't have a corridor that's straight enough to put a straight screw, then you can cheat and go over to the other side. So I would say this would be more the future rather than cementing itself by itself.
Thank you.
Always, Abdullah, always all teaching to try to fix a fracture or wait until if you don't want to operate on the patient, especially old patient, 3 to 6 months for consolidation to go for a hip replacement. Sometimes for many things you can go for a hip. One thing I noticed, at least during my practice, that whenever you have a comminuted acetabular fracture, old patient, and you need to get him ambulated, you took the decision to go for arthroplasty to do a distraction technique with the graft. Like you put the graft and you distract, you put the graft and distract. This will help to give you a more, and then you put your ring, which is the molar or the Gans ring or whatever, and you fix it. I noticed one thing, whenever you do this, the risk of failure is low. Whenever I was using the Berg-Schneider, the bone grafting and Berg-Schneider, the failure, I had failure at 5 years, I had failure at 3 years. But with the compaction grafting and distraction, I cannot say I didn't have failure because some patient died, some patient I didn't see afterward, but the result was much, much better.
And I would like to add also, Rida, that for these ones, it's important to reconstruct your columns because your cup is really, you're fitting your cup between basically 2 points of fixation.
You are right, but this is what I'm saying.
Yeah.
I distract and I bone graft. Like انك عم تعمل مثل الميلج. I distract and I bone graft to reconstitute the columns, and I use the hernia mesh that the general surgery do to isolate the internal structures. I think it works many times.
And one more thing about the delayed THA, I mean, the common thinking is when you delay the THA, you're kind of deconditioning these patients. Because if they spend 3-4 months, waiting for their THA, they're not really walking, they're not doing much. So when they come back for their second surgery, this is why probably the complication risk is a bit higher, like DVT, things like that. So if you have the expertise of doing it right away, I would say just do it right away.
Hello.
Yes. Yeah. Yeah. This is an excellent point. If you're able to do it that way, I do it that way. The patient stays supine. You do a stoppa. You put in your plate with an extension over the quadrilateral plate, and then while the patient is still supine, you go in. You put a multi-hole cup, and the patient gets up the next day.
But
correct.
But the problem, Alan, in these cases is not the anterior column. As a joint surgeon, the anterior column, we're going to give a damn for it. We just graft it. The problem is the posterior column.
In that case, you can combine posterior screw. It depends on the comminution that you have. And sometimes it depends on the acetabulum that you're using. You can use acetabulum with some screws to fix the posterior column.
What do you mean? But these are osteoporotic patients. Do you think one screw is enough to hold it?
I'll show a case, Rida Hala. Once we show the cases, I actually have a case like that. So. But can you put my presentation number 2? Because I think it's an important point. I'll just show it. It's really quick.
We need to apologize to all the group. Will not be able to proceed with the next session because there is a session that's going to start in 5 minutes, in 3 minutes actually. So 5 minutes. So we'll not be presenting cases because of so. Can you present the acetabular case, please?
So this is like what I meant about small pathways, like Alain was asking. Like there's not enough place to put actual. But this is this one. So this is a case where you have an anterior column with a posterior hemi. The medialization of the femoral head, quadrilateral plate broken, blah, blah, all that stuff. This is how it looks on the CT scan. So this was done supine. This is the plate from the stoppa approach. You can see the same setting. You go in and you can do an anterior hip, and this would be the results, and patients.
هلا do you see a lot of heterotopic ossification, especially after this approach, like
No.
the stoppa combined with the hip replacement?
No. Personally, I mean, the most HO I've seen while doing acetabular surgery from the posterior approach. Especially the posterior columns with posterior walls with dislocations. In my hands, these are the ones that really develop a lot of HO.
Because we see a lot of HOs through the anterior and the stoppa approach, and we have cases.
Was it
Actually, going
modified?
to revise case next week.
That was a modified stopper. In fact, you're not dealing a lot with bone, and you're just putting
Yeah.
the plate as an
As
internal
only
reduction. So you're
but
not
still-
manipulating.
But still, there is one thing, because of the posterior column, as a posterior surgeon, for me, a posterior column is very important. So how one screw can fix the posterior column to put a cup? This is what I'm asking.
So so if you look at this plate specifically, it has an extension that goes down the quadrilateral plate. So it really going, and then I add more screws. Yeah,
Allah, you had both columns fractured here.
yeah,
So done also from a posterior approach,
yeah,
plating posteriorly,
yeah,
using a cup with
yeah. You can, but I would also suggest you add an anterior column screw as well. So,
Can, as Alex said, you can pattern because approach and you do your
but I do them anterior, so it's supine. I don't go posterior. So the patient is just flat, and you do everything from the top. But you're right. You have to plan if you're going stop and then going posterior. You have to be careful what you're doing.
Still have one question, time for one question. علقونا على دوي شو شباب وين residents ما في questions ما قلنا there is stupid answer not stupid questions شو وين الحلبة طيب thank you all for your presence, thank you Abdullah again.
Thank you.
And thank you for this present. Now we'll be moving for the next session. لا مش الافتتاح في عندهم هن سيمينار.
بفتحها. هاي شو بنعتبرها؟ يعني انا ما راح احط اندو راح راسي انت بس بنكر disconnect. Yeah.
Test, test.
يلا نبلش. يلا. So, good morning, dear colleague and friends. It's as usual every year. It is an honor and privilege to welcome you to this scientific meeting, the shoulder session. We all of us know that our country face a huge instability, and maybe being here, it's not from your top priority. Your presence here expressed our big sign of resilience, dedication to work, and also continuity. Thanks for all of you for being here. Thanks for Dr. Ali Shamsuddin for the big effort, the president of the Lebanese Society, who makes this meeting possible. And let's start and enjoy this meeting. Just to mention that we choose all the topic to be helpful in our daily practice in Lebanon. Thank you, Dr. Ali Shamsuddin. Please. We start with Dr. Muhammad Nasr al-Din. طلعت في البرك مش
حسب البروجرام.
اوكي.
علي شمس الدين.
La target procedure.
Thank you, George. Thank you, Rami. This is one of my favorite procedure. George will not be happy now. So, بلشنا. Lyon is a city located in the Auvergne-Rhône-Alpes region in France. It lies at the confluence of the Rhône and Saône rivers at a hilly site, very nice, beautiful hilly site. And it is precisely in Lyon where the history of this procedure, the Latarjet procedure, started around 70 years ago, more than 70 years ago, when Michel Latarjet reported in 1954 a procedure he performed on 2 patients for recurrent shoulder dislocation 1 year before. The first irony of history is that Michel Latarjet was not an orthopedic surgeon. He was an anatomist, and in 1946, he was entitled a professor of anatomy at Lyon University when he was only 33 years old. And he was a general surgeon with a special interest in thoracic surgery. In 1958, he was appointed head of the thoracic surgery department at Jules Courmont Hospital. He was only 45 years old. The second irony of history is that Michel Latarjet was working in the same hospital as the very famous Albert Etria. Albert Etria was recognized as the father of the orthopedic surgery in Lyon and had an international reputation for his innovative ideas in shoulder and knee surgery at that time. In this photo on your left hand, you see Albert Etria, with on the left Gilles Bousquet, who invented the dual mobility cup of the hip, the double mobility cup of the hip. And on the right, you see Henri de Jour, the very famous Henri de Jour. The third irony of history is that in the same year, 1954, in the same issue of the same journal, Lyon Chirurgical, issue number 8, Albert Tria and Michel Latarjet reported their personal techniques for recurrent shoulder dislocation exactly one after the other in a pagination. The paper by Albert Etria ended in the page 993, and the paper by Michel Latarjet started in the page 994. Albert Etria's procedure consisted of 3 steps. The first one was arthrotomy with vertical division of the subscapularis to treat the Broca lesion, which was called in the French literature, which is the name in the French literature of the Bankart lesion, and to enhance its healing. And for the sake of history, Broca lesion was described by Auguste Broca more than 50 years before the description made by Professor Bankart. And for the sake of history, Auguste Broca was the son of Pierre-Paul Broca, who described the Broca's center of speech articulation in the posterior part of the lower frontal winding of the left hemisphere. And the second step of the procedure described by Albert Etria was an incomplete osteotomy of the coracoid process with a preservation of its periosteal sleeve. It was an inferior closed wedge osteotomy without completely breaching the coracoid. And then a bending with lowering of and fixation of the coracoid, a process to the neck of the scapula using a screw or a nail. The aim was to make like a safety stop or abutment to the anteromedial displacement of the humeral head by closing the glenocoracoid pathway anteromedial to the humeral head. Michel Latarjet himself stated that he was impressed by the results of the Bankart procedure, and he was also aware about the evolution that Albert Triat made in the field of this surgery. However, he decided to see by himself, because he was anatomist, so he decided to see by himself the preglenoid anatomical lesion. His deep sense for the anatomy pushed him to explore the anatomical lesions encountered during surgical treatment of recurrent anterior shoulder dislocation, and he noticed the constant presence of the labral lesion, or the tear of the labrum, and the anterior chamber of the pouch of dislocation just underneath the periosteal sleeve, in the deep aspect of the subscapularis. Now, for the fourth irony of history, according to Gilles Walsh, the famous Gilles Walsh, the shoulder surgeon Gilles Walsh, according to him, it seems that one day in 1953, Michel Latarjet visited the orthopedic theater of Albert Etria to watch him performing his procedure. And Michel Latarjet then tried to perform the same procedure for one of his patients. And during the surgery, he was embarrassed as he accidentally fractured completely the coracoid process with the coracobiceps tendon still attached on the tip. So Michel Latarjet had the brilliant idea to take a screw and to fix the coracoid fragment directly to the anterior glenoid rim after anterior arthrotomy. That was presumably the beginning of the Latarjet procedure, accidentally. And the beginning of a great animosity between Albert Triat and Michel Latarjet, most probably because that Albert Triat was considered as a significant figure and uncontested master in the field of orthopedic surgery, and Michel Latarjet was a general surgeon. He was an intruder, so this was not well seen. In opposition to Albert Triat, Michel Latarjet didn't have orthopedic fellows or students to bear his ideas. The fifth irony of history, in December 1955, Michel Latarjet went to Paris at around 400 kilometers from Lyon, seemingly to get validation and recognition for his procedure. He was invited by the very famous Professor Robert Maire d'Aubigné to present his personal technique in the orthopedic meeting in Paris at Cochin Hospital, as he reported in his paper in 1958. In addition to the first report in 1954, Michel Latarjet made 3 more written reports on the technique. In 1958, in Lyon Chirurgical, about 9 cases. In 1961, in the journal Mémoires de l'Académie de Chirurgie de Paris. In 1965, in the same journal, Lyon Chirurgical. the sixth irony of history, none of Michel Latarget's papers or reports were published in any orthopedic journals, which I believe may suggest that he was prohibited from publishing within the community of orthopedic surgeons, because he was an intruder. He was a general surgeon. In the 60s and 70s, according to Gilles Walsh, the influence of Professor Triat in France was such that the only procedure to compete with the Bankart operation was the Triat procedure. Despite 14% of recurrence rate, which was published 1 year after the departure of Albert Triat. ما كانوا يسترجوا يحكوا قبل هو عايش. So they waited that to publish. So it seems that Michel Latarget failed to get extensive recognition or widespread diffusion for his procedure. In the 80s, Didier Pat, a leading shoulder surgeon from Paris, brought to life and endorsed the Latarget procedure as a mainstay treatment for recurrent anterior shoulder dislocation. He was given the task to develop a chapter on the surgical technique in the French Medical Surgical Encyclopedia of Surgery. He insisted on 3 technical steps, making what he called the triple blocking principle: an L-shaped division of the proximal part of the subscapularis, preserving the lower 1/3, a solid fixation of the coracoid block flush to the anterior glenoid rim with its upper limit at the equator of the glenoid at 3 o'clock. And finally, the 3rd step was a suture of the capsule to the stump of the CA ligament and the coracobiceps tendon. 2 decades later, in the 2000s, many publications demonstrated the significant biomechanical efficiency and effectiveness of the triple blocking principle, which became the underlying principle of stabilization of the Latarget procedure: the bony effect, the capsular effect, and the muscular effect, the sling effect. In 1985, Gilles Walsh visited Didier Pat, so he went from Lyon to Paris to watch him performing the Latarget procedure, while the Latarget initially was in Lyon. So, for the 7th irony of history, Gilles Walsh from Lyon brought back the Latarget from Paris and reintroduced it to Lyon, precisely to the department that was headed by Albert Triat one day. This was only possible after the retirement of Professor Triat, who was still extremely upset about Latarget, according to Gilles Walsh. In 1990, Gilles Walsh organized a round table during the spring meeting of the French Society of Orthopaedic Surgery, the SOFCOT, in a tribute to Didier Pat, who had passed away in 1989. He emphasized that Didier Pat insisted on the reconstruction of the capsule during the Latarget procedure. When we go to the literature, we can see that the reconstruction of the capsule has seen many modifications through the years. It started with no repair, then repair to the stump of the CA ligament, then repair to the anterior glenoid rim. For the 8th irony of history, a careful reading of the first report by Michel Latarget in 1954 clearly reveals that the reconstruction of the capsule is an important step. He precisely advised that the capsule should be reconstructed and sutured to the coracobiceps tendon, and the coracoid block should remain extra-articular. In the 1990s, Gilles Walsh endorsed and popularized the triple blocking principle, and he promoted a modified technique of horizontal split of the subscapularis. The management of the subscapularis has gone through many modifications in the literature. It started with a complete vertical division, then a partial vertical division of the proximal part, according to Pat, then a vertical division of the distal part according to Weaver, and finally, what we are doing nowadays is the horizontal split. Okay. Okay, so you can see the evolution of the division of the subscapularis through the years, from the complete vertical split to the vertical split of the proximal part, as reported by Didier Epat, and the vertical division of the distal part as reported by Weaver, and finally the horizontal split as promoted by Gilles Walsh. Ninth, irony of history. The illustration included in the Latarget's first report in 1954 clearly shows a horizontal split of the subscapularis, just as we are performing nowadays. So the same horizontal split. However, in the following descriptions, in 58, 61, and 65, Michel Latarget advised a complete vertical split of the subscapularis. So he changed the first description, and this was to allow a wide exposure of the joint and a suture application of the subscapularis, as known as the petit plate technique. In 1998, the team of Professor Dominique Salagaglia in France, in Grenoble, France, reported that the complete vertical division of the subscapularis, as performed at that time, induces a fatty degeneration of the subscapularis in 41% of patients, a decrease of 50% of the thickness of the subscap, decrease of 50% of the strength of the subscap, and a decrease of around 50% of the range and force of internal rotation. So he advised to abandon the complete vertical split, and he advised to do the Weaver technique, the vertical split of the lower third of the subscapularis. In 2008, the same team, also headed by Professor Dominique Salagaglia, compared the Weaver type division of the subscapularis with the complete division of the subscap, and there was no fatty degeneration of the subscap of grade 3 and 4, no decrease of the thickness of the subscap, and a decrease of only around 18% of the strength of the subscap in internal rotation, as compared to around 50% by the complete division. So he advised abandoning the complete division and to adopt the vertical split of only the lower part of the subscapularis. In 2005, the team of Professor Henri Mesdag in Lille, France, reported that the division of the proximal part of the subscap, as initially reported by Didier Pat, compared to the horizontal split now, as reported by Gilles Walsh, results in marked fatty degeneration of the subscap, significant atrophy of the subscap, decrease of the strength of the subscap, and decrease of the range of internal rotation. So he advised abandoning the vertical division of the proximal part, and he adopted the horizontal split as described by Gilles Walsh. In 2006, Nourissa was the first to describe an arthroscopically assisted Latarget procedure in a cadaveric study. In 2007, 1 year later, two reports on the clinical application of the arthroscopic Latarget were reported separately by Boileau and Lafosse. An expert opinion by Laurent Lafosse, who had performed more than 700 arthroscopic Latarget up until the year 2018, he said that although the arthroscopic Latarget technique is nowadays perfectly codified, every step remains difficult and tricky. And nevertheless, in our hands, in his hands, each arthroscopic Latarget remains a challenging procedure, and it is always possible at any stage to convert the arthroscopy to an open technique. A good open Latarget is much better than a bad arthroscopic Latarget. Another expert opinion by a renowned arthroscopy and shoulder surgeon from USA, Matthew Provencher, he stated that although arthroscopic techniques are gaining momentum, open Latarjet remains the gold standard. Latarjet procedure is one that has clearly stood the test of time and is likely here to stay. The history of the evolution of the Latarjet procedure is important to know for more improvement to the surgical technique. The procedure described in the first report in 1954 has evolved to become a cornerstone in the treatment of anterior instability of the shoulder. The basic principles of the procedure have demonstrated effectiveness and reliability over years. Although the surgical technique has been modified over the past decades, the essential and basic principles remain the same around more than 70 years. More than 70 years after. The biomechanics of Latarjet procedure has definitely proved that the addition of bone to the glenoid rim increases the anterior posterior osseous diameter of the glenoid. The conjoint tendon acts as a sling to the inferior subscapularis and anterior inferior capsule when the arms is abduction and external rotation, and the CA ligament reinforces the inferior capsule. This is the last slide. Michel Latarjet succeeded to treat recurrent anterior shoulder dislocation by eliminating the lesion described by Auguste Broca in 1890 and known as a Broca lesion or the Bankart lesion, if you want. But in the French literature, it's known as the Broca lesion. And Michel Latarjet, he passed away in 1999 from a CVA with right hemiplegia and Broca aphasia. So the last irony of history, Michel Latarjet was killed by a brain lesion to the area described by Broca the father, although he successfully eliminated the shoulder lesion described by Broca the son. Thank you.
Thanks, Dr. Ali, for this flight back in time and for those valuable information. Is there any question?
No fact. But I mean, why they added soft tissue reconstruction? It's like they are doing combined procedures. I mean, Latarjet procedures, and they added later a soft tissue reconstruction. I mean, it's like doing both procedures, Bankart repair and soft tissue. I mean, this is a bias.
You know, George, I think this is the eternal débat between you and me, and between those who perform the Latarjet and those who perform the Bankart. If you have a bony lesion, I don't understand how you can reconstruct. I remember when a few months ago in Hotel Dieu, when there was the meeting, the Kharrat, the Dagar Kharrat days, ما هيك كانوا. هلا حسن بيضون مش هون، بس وقتها ما قدرنا نحكي لأنه كان الوقت صار كتير صغير قصير. Hassan Baidoun, he presented about the bank, about the remplissage with the Bankart and etc. And he said that when he is doing this procedure, the Bankart with the remplissage, there is a transposition of the center of rotation of the shoulder posteriorly. He stated clearly in the presentation, based on the literature. So, and we know very well, it's also stated in the literature, then that when you transpose the center of rotation posteriorly, you increase very, very much the risk of osteoarthritis. I don't know if Rami agree with me, You will not agree, George. I know.
because it's
No,
not-
I don't agree or not disagree, but I have a small remark. As I have been in France for 2 years with shoulder surgeon, there were some surgeons who are not doing this capsular reconstruction,
The same.
and other surgeons are doing the capsular reconstruction. We had the chance to see the difference between them. The only difference is those who were, we have done the capsular reconstruction have less apprehension in extreme abduction and external rotation. It does not act on the recurrency rate or on the performance. It only acts on the apprehension in extreme abduction and external rotation.
No, but when you looked at the old literature, when there was only the open bankard or the arthroscopic, the bankard from one side and the Target from the other side. When there were these two procedures, the literature of the bankard stated at that time that the recurrence rate is almost similar to the Latarjet. Then suddenly they discovered that this is not true, and we should add the شو بتسموها remplissage technique to reach a level of recurrence equivalent to the bankard. What about all the old literature that stated that the bankard alone is enough? It is the panacea. It is equivalent to the Latarjet. So I don't know. The literature is either a false literature or عم بيكذبوا, or there is something wrong in the literature, because now with the remplissage they say it's equivalent to the Latarjet in the rate of recurrence, etc.
Yeah.
Now for the osteoarthritis, I don't think that the Latarjet is superior, has more than osteoarthritis. We should differentiate, because with the bankard we are operating more and more from the first dislocation. So, and this is a very big bias in the literature, very big bias. When we operate a patient with a first dislocation, and when we operate a patient at, for example, 45 years with a first dislocation, we do a bankard, etc. So there is a big bias, I think, in the literature.
No, this is according to Dr. Boileau and Gilles Valge, and it's French literature that 40 to 45% after 25 years long-term follow-up, they develop, all of them, osteoarthritis. I mean,
there is a very nice paper by Goutalier in the GBGS. Very nice paper by Goutalier in GBGS with 25 years follow-up, showing that the osteoarthritis is of grade 1 and 2, mostly, not 3 and 4, and it is related to the number of the dislocations before the procedure. So the more, because at that time we didn't operate, we didn't have the trend to operate from the first. So the patients, they have to wait for the 10th dislocation, 15th dislocation, 20.
yeah, but
then
Ali,
operate.
I mean, grade 2 at 35 years, it means grade 4 at 45.
No, not at 35, not at 35.
It's a progressing disease.
Read. There is a very, very nice paper by Goutalier, Anjad, really, with the 25 years follow-up of Latarjet procedure, and he analyzed all the factors for the recurrence and all the factors for the osteoarthritis. Very nice paper, in details. يمكن حوالي 10 صفحات بيطلع البيبر. Very nice paper by Goutalier, the famous Goutalier, who made the score for the fatty degeneration of the rotator cuff.
Okay, thank you.
Thank you very much.
Both operations are giving good result. We will proceed with Dr. Vatche Courtian, who will speak about failed bankard repair, what to do. Certainly not a Latarjet. Thank you, Vachi.
Good afternoon. Thank you for having me. So I was asked to speak about the failed Bankart repair, what to do. So I want to start with an introduction to shoulder instability. The shoulder is the body's most mobile joint, so it makes it more susceptible to dislocation. The first dislocation usually is caused by a trauma, and 95% of the cases we have an anterior shoulder dislocation. 70% of the patients will develop recurrent instability, and the younger the patient, the greater the risk of recurrence. You know, although you all know that the two main pathologies encountered in anterior shoulder instability are the Bankart lesion and the Hill-Sachs lesion. Bankart lesion is the disruption of the anterior inferior labrum from the glenoid. It was first described by Broca, like Dr. Ali Shamsuddin said, then by Perthes, but it was popularized by Bankart in 1923. Later, many other variants of the Bankart lesion were described. The second pathology is the Hill-Sachs lesion, which is a compression fracture of the posterior lateral surface of the humeral head caused by the impaction on the anterior inferior glenoid rim. Many authors had described it, but again, it was popularized in 1940 by Hill and Sachs when they published 119 cases in the Journal of Radiology. Historically, in the 5th century, Hippocrates studied these patients. So this is an old pathology. And he described cauterization of the lower part of the front of the shoulder with the red hot iron as a treatment. Of course, the idea behind this was to have a scar tissue in the anterior shoulder to limit external rotation so that they will not have a recurrent dislocation. Later, most of the surgical techniques that were described to treat anterior shoulder dislocation relied on the same principle, limitation of external rotation of the shoulder. These are some of the techniques that were used to treat these patients. Of course, today we will talk about the Bankart technique, which was described in 1938. It was a repair of the capsulolabral complex on the anterior inferior glenoid rim. And of course, we have the Latarjet de Bristol that Dr. Ali Shamsuddin talked about. So the early reported recurrence rates following an open Bankart repair varied between 4 and 6% recurrence. Then we started doing arthroscopy of the shoulder. Arthroscopy of the shoulder was initially described by Burman and Takagi in the early 1930s. Initially, it was used only for diagnostic purposes. In 1982, the first reported arthroscopic surgery of the shoulder by Wiley and Alder. The early methods of instability repair included resection of the torn labrum, modified Bankart repair by transosseous sutures using K-wires, anterior inferior glenohumeral ligament substitution by fascia lata allograft, staple capsulorrhaphy, screw capsulorrhaphy, capsular plication, and the worst, electrothermally assisted capsulorrhaphy, which was described in 1995. Unfortunately, these techniques didn't give us good and satisfying results. But with time, with the advancements of the materials, the tools, and the techniques, arthroscopic Bankart repair became more reliable and reproducible. And the early recurrence rates of suture anchor arthroscopic Bankart repair were very variable. It varied between 10%, 8%, 7%, 4% to 35%. I think this was due to the learning curve and the difficulty of the technique. With time, we started seeing studies comparing the open and the arthroscopic Bankart repairs. And with time, most of the studies showed that the two techniques, the open and the arthroscopic repair, had no statistical difference between the for recurrence rate. This is one level 1 and 2 study, systemic review. Another one, it was published in 2013, 1,780 patients, no difference in recurrence rate between the arthroscopic versus open repairs. This paper, the meta-analysis from 2014, showed that the recurrence for open was 8% versus 11% with arthroscopic repairs. But if we looked in more detail, she realized that the patients treated with anchors, because this group included patients who were treated without anchors, the people who were treated with anchors had similar recurrence rate as the open repair. So, what does this mean? It means that, yes, we have recurrence rate. We have failure in Bankart repair, both in the open and the arthroscopic. So, we would like to know, why does this technique fail? So, we have several causes. We have patient factors. The patient may be subject to retrauma. What I usually tell my patients, that if God's creation and you dislocate it, you will dislocate my repair. I can't do better than God, okay? Especially if they are participating in contact and collision sports. Non-compliant patients, males tend to recur more than the females, younger patients more than older patients. It depends on the chronicity. It means that how long did the patient wait until he had his repair done? The soft tissue condition, if he has laxity, capsular stretching, like the people who have voluntary dislocation. The second factor is the surgical technique. Surgeon's experience. This technique has a learning curve. And of course, if the surgeon is not experienced, at the beginning, he will do mistakes. For instance, you can see here, you can see the anchors are too medial. So this patient will fail. If we have missed pathologies like an engaging Hill-Sachs lesion, again, here, if the surgeon didn't treat this engaging lesion, the technique will fail. If the indication was not right, it will fail. The tools, the materials used, if not enough anchors were utilized, of course, will not have a good repair. And of course, the most important is the bone loss, the glenoid bone loss, the humeral bone loss, the bipolar bone loss. This all should be taken into consideration. The concept of engagement was first reported in 1948. Then Burkhardt made it more popular. He came up with the critical glenoid bone loss, which was 25% of the surface of the glenoid, or 6 millimeters. In 2007, Yamamoto made more detailed research on this, and he came up with the glenoid track, etc. I will not go into these details, but what I want to say that the glenoid bone loss and the humeral bone loss are very important factors. Now I will go to the practical. I will share with you some of my experience cases that I've seen, I have treated. I will start with the first patient. This was a 20-year-old male patient, right hand dominant. He's a very active guy, very active guy. And he had a left shoulder recurrent anterior dislocation since 4 years. Of course, it had started after a trauma. So, unfortunately, I don't have the pre-op images. I've lost them. But in April 2017, I did an arthroscopic treatment for this patient. He had a type 2 slap lesion, which was repaired by one double-loaded anchor, and also he had a Bankart lesion, which was treated by 2 double-loaded anchors. He didn't have a big heel sac lesion, and also we were limited by the insurance. We had only 3 anchors to use, so we didn't do any remplissage. So just to show you how active this guy is, 14 months later, again, he was doing some activities. He dislocated his right shoulder, the other one. A year later, he gets into a skidoo accident. This is the image he sent me, actually. So this is his skidoo, and he was trying to climb that hill on a skidoo, and he flipped along with the skidoo, and he dislocated his shoulder, the operated shoulder, and he was taken to a nearby hospital, and it was reduced. And he came after a couple of days for follow-up. Again, we took x-rays. We had a bony Bankart lesion. The shoulder was reduced. And here the patient, he decided that he doesn't want to be operated. He will continue with a conservative treatment. That's what we did. But 6 months later, the patient comes with a recurrent shoulder dislocation, left shoulder. We did an MRI. You can see that we have a large glenoid bone loss, bony Bankart due to the bony Bankart. And here, when we have bone defect, we will do a bony procedure. So I performed a Latarjet in 2019. Again, I don't have the x-rays. I saw the patient the beginning of this year at 5.5 years post-op, and he had a good function and no recurrent dislocation. And this is his control x-ray 5.5 years later. Second patient, 21-year-old male, right-hand dominant. He's a handball player. He had, at another hospital, undergone right shoulder arthroscopic Bankart repair 2 years ago. He was doing relatively well, no dislocations for 1 year. Then, after a small trivial trauma, he had dislocation and the recurrent anterior dislocation. So here, I had to take a decision what to do. منجرب المجرب, or we go for a bony procedure. But on looking at the MRI closely, I realized 3 things I want to share with you. First, we don't have a large glenoid bone loss, okay? We have the Bankart lesion, but the glenoid bone is not that much damaged. Second, we have a large heel sac lesion, and there is no evidence that a remplissage had been performed previously. And thirdly, most importantly, I don't know why the pointer is not working. The previous anchors were inserted in the middle of the glenoid, on the articular surface, on the cartilage. So I thought there is no way for this capsulolabral complex to heal on the cartilage. It will not heal. So I decided to do a revision arthroscopic Bankart repair. And this is his intraoperative images. You can see the anchors are on the articular surface, on the cartilage. And some of the sutures have been cut, the others were still holding, but the complex was gone. It didn't heal. It could never heal on cartilage. It needs a bleeding bone to heal. So we removed the old sutures, performed another Bankart repair. Here you can see where the old anchors were and where the new anchors were inserted. I also performed a remplissage to this patient. And in the end, we had a very well-centered shoulder joint. You can see on the far right. And at 7 years follow-up, the patient still is doing very well. No pain, no instability. He's playing his sports and has full function and activity. Third patient, the last one, this was a 14-year-old boy. I know I'm pushing the limits. He's 14, but his right shoulder dominant. He had a left shoulder recurrent anterior dislocation starting at the age of 12. But he is a lazy guy. He doesn't do sports. He has joint laxity. He didn't have significant glenoid or Hill-Sachs lesion, glenoid bone loss or Hill-Sachs lesion. So again, I decided to go with an arthroscopic Bankart repair for this guy. This is his surgical images. You can see the Bankart lesion. Here we are viewing from the posterior portal, the superior lateral portal, and we performed Bankart repair with 3 knotless anchors, and we didn't do any remplissage because, as I said, the Hill-Sachs lesion was shallow, it wasn't deep. This is the patient 2.5 months later. He is very happy, as you can see. He has good function, good range of motion. 2 years later, he's playing with his friend, and his friend pulls his arm, and he comes with a shoulder dislocation. A close reduction in the emergency room was performed, and I treated the patient as a first-type dislocator. I put him in a sling for 10 days, and I asked him to put the sling for 1 month, 20 days more after the reduction. And for 5 years, he was doing very good, great. 5 years later, meaning 7 years after the Bankart repair, he gets into a motorcycle accident. They send me this X-ray. He has a clavicle shaft fracture, comminuted fracture. And knowing the patient and seeing the X-ray, I didn't like the shoulder. So I asked the residents to give me an X-ray of the shoulder. This is what I got. Posterior dislocation. They also did a CT scan. He didn't dislocate anteriorly. He dislocated posteriorly. And again, I want you to pay attention to the location of the anchors. It's on the corner of the glenoid, okay, the old anchors. They are not on the glenoid articular surface. And we did a close reduction of the posterior dislocation, internal fixation of the clavicle. This was a year ago. 2 months later, he already had a good function, and he's still doing good. So, my take-home message for you is most traumatic redislocations after Bankart repair can be treated as primary dislocations. Not the end of the world. If they redislocate, especially after a trauma, you can treat them as primary dislocations, reduce it, put him in a sling, than hope for the best. We should understand the reason for failure. Try to understand the reason, why it failed, and treat the reason. Understand the patient. The first one, the active guy, maybe I should have done bony procedure earlier, knowing that he's a very active guy. So you should know what are the patient's expectations and what are his goals in life. And finally, the surgeons, they should understand themselves. Understand yourself. Know what you are able to do. Think if what you're going to do, if you can do better than what has been done. If not, leave it for someone else. Thank you very much.
Thank you, Dr. Cortion. Any question? No, I have a question for you. Maybe the patient, he did not have dislocation again after conservative treatment. Maybe he stopped all kind of sports after surgery. I mean, it's happened to me. It's not because treatment is good. Is because after surgery he stopped sports and that's it.
The third one, you mean?
Yeah.
The third one already didn't do any sports. He's a lazy, I know the family, I know him. He's a lazy guy. That's why at the age of 14, I decided to do a bankart for him. Because he sleeps all day. So he's not an active guy. So his activity level did not change. Okay? But he was in an accident.
Because you mentioned that he has laxity before. He has laxity.
He has laxity.
He performed anterior shoulder and then posterior shoulder. It means that he may have multi-directional instability.
But as I said, after being in an accident, a big accident which caused a fracture of his clavicle, his shoulder dislocated posteriorly, not anteriorly. I know that maybe the power of the force of the trauma was in that direction. But if I had permanent anterior instability, it should have gone anterior. Okay? This is my idea.
Okay.
Okay?
Okay.
Thank you.
Now we will proceed. There is a change in the program. As Dr. Noon will not be with us, Dr. George Rasi will give a talk about tips and tricks to improve arthroscopic anterior shoulder instability treatment.
Dr. Noon, he's not here. He will not be able to join us. And Dr. Hisham is in North Lebanon. So I will give a talk about how to improve results after arthroscopic bankart repair. So let's start from the beginning. Here is Dr. Frederick Madsen from Washington, D.C. He stayed all his life to study shoulder instability. I mean, he came out that he was in the military hospital in Washington, D.C., where there is a lot of shoulder dislocation from soldiers. And he came out after all his work to say that bony configuration and shoulder instability does not matter the outcome of shoulder instability. A lot of people before us, they try to do, for example, derotation osteotomy of the proximal humeral, osteotomy of the glenoid. It does not work for shoulder instability. So bone reconfiguration in shoulder instability does not affect the outcome. And here from Dr. Matson that he said that chant the labrum here, just the labrum, it is we consider it a small anatomical fracture, but it has a big role and it acts as a choke block, and it will inhibit the anterior shoulder to translate anteriorly. And he came out with the theory of vacuum, and he said that just to create a small hole in the labrum and capsule, it will decrease the instability by 50%. Here, just to consider the vacuum effect, a lot of us, when we are doing anterior Bankart repair or even Latarjet procedures, we don't do examination of the insertion of the glenohumeral ligament on the humerus. And here, for example, when he started doing the father of shoulder instability and shoulder surgery, Dr. Charnier, in 1970, he beginning for surgical treatment of shoulder instability to do repair from the humeral side, because he considered that the pathology, his opinion, it is from the humeral side and it is not from the glenoid side. And after him, Dr. Frank Job, he began to do instability from the glenoid job. Just to say that we have to test the instability and the laxity before doing any glenohumeral instability, even it is a arthroscopic or open or Latarjet. We have to test to do the Hawken test, and there is a lot of way to test glenohumeral instability. We can test it by percentage of translation of humeral head, by millimeter, by centimeter. So for me, we tested in our book we did with Dr. Edward McFarland, and he showed us how to do very, very simple exam in the clinic, just to do modified Hawken test, just type 1, type 2, type 1, if we can reach the anterior border of the glenoid, type 2 if we can dislocate. This is the easiest way. It is very difficult to measure it by millimeter or by percentage of, we need a lot of radiograph. So the success of capsulolabral repair, it is beginning from the clinic, really. So here, by doing a simple history and physical examination, all those patients, they are not candidate for arthroscopic Bankart repair. I mean, regardless of the bone loss or for the extension of soft tissue or bony component. For example, this patient, she has a generalized laxity. The other is a very professional athlete. The other has multi-directional instability. Other has voluntary instability of the shoulder. All of those patients that are not candidate for even arthroscopic or open capsulolabral repair. Also, although by after when are going to X-ray, when are doing radiograph, and we found that we have more than 25% of glenoid bone loss, or more than 30 to 40% of humeral bone loss, those patients that are not candidate for capsulolabral or Bankart repair. So success begins with selection. There is a big bias when we are doing capsulolabral repair for all patients. Anterior glenohumeral dislocation, it's not a Bankart repair. It's a lot of pathology. We may have torn of the capsule, labrum, capsule and labrum. We have Hagel lesion, Glad lesion, Alapsa, Hill-Sachs lesion. We have to repair all those lesions. Here by the French Society of Orthopaedics, they come to a conclusion that
Bankart repair, typical Bankart repair from 1 to 5 o'clock does exist in only 30% of patients. And the other 70% of patients, they may have capsule or labral tear from all around the glenoid. So be careful. Anterior glenohumeral dislocation, it's not only a Bankart repair, Bankart lesion. Here, for example, a study that said that 4% of patients, they may have intrasubstance tear. I mean, they have a patient coming to us, and he has anterior shoulder dislocation. We enter the scope. We did not find any Bankart lesion, Here is one of our patient. He has a anterior glenohumeral dislocation, and we found he does not have any by arthroscopy and by MRI. He does not have any Bankart lesion. He does not have any Hagel lesion. He has intrasubstance tear. And we go by arthroscopy, and I put side to side repair of the ligament. Here's our patient. It's obvious. Here's just a lot of study here that says that capsular laxity, it is an issue in anterior shoulder dislocation. It's not only Bankart repair. For this reason, we have to understand what to do. I mean, surgeon, he has the philosophy of anterior shoulder dislocation before going to surgery. He should mention in his mind that he may have a labral tear, he may have a capsular tear from all around the glenoid side. Here, anchor placement. Also anchor placement, Dr. Cortion, he mentioned it, that before they are putting, here there is no pointer here, it's okay. Before they are putting the anchor here, after understanding the physiopathology, they put it here, and now they are put it here. But also there is a mistake because they should remove the cartilage from here. Here a Hagel lesion. Here is one of our patients. He is one of my patients. He has 2-time recurrence of Bankart repair. And I entered by arthroscopy, and I found that this patient has disinsertion of capsule from the humerus. I mean anterior, from the anterior humerus. It's not from the glenoid side, the pathology. It is from the humeral side. And I went and I repaired it is from 10 years. I repaired the capsule from the anterior to the humeral head, and the patient is excellent. Here is MRI, and here's the arthroscopic finding and repair. Glad lesion, one of our patients, he has, so just to mention that we have to repair also the glad lesion. Alapsa lesion, there is a big bias in alapsa lesion when we have a lot of failure. I mean, we have to do complete dissection from 12 to 6 o'clock. Like an open surgery, we have to dissect all the capsule from the subscapularis, and here our sign, we have to repair all of them. I will not go into details, but just to mention that we have to do complete release from 6 to 12 o'clock in Bankart lesion. When we do arthroscopic, our colleague, young arthroscopists, when they are going to do this surgery, we have to do release from 12 to 6 o'clock. It is mandatory. We have to do complete separation, like here, complete separation of the capsule from the subscapularis. Okay, done just, Bankart repair, it is not just to grab the labrum anteriorly and to put the anchor and to tie it. We have to do complete release. Third, you have to use, when we have a lot of capsular laxity, a stitch to improve the vision. To remove, to know how to use the instrument, we have to use a stitch. We have to expose 1 to 2 millimeter from the rim anteriorly to improve healing of the capsule to the bone. It is very important. Look the bridge here, 1 to 2 millimeter. You have to create it. Debridement under bleeding bone, like we can say here, don't do over debridement, but just you have to do debridement. I mean, debridement and preparation before putting the suture, it will take maybe the half of the time of surgery. I mean, you have to spend time doing this. You have to spend time doing this. Good debridement at 12 o'clock and like this all around the glenoid. I mean, this is we are superior. Sometimes we are going to surgery and we found that we have the lesion all around the glenoid. We have to do a complete debridement. For me, we are publishing this in the Journal of Arthroscopy. We call it wave sign. So we have, when we create a negative pressure, we should have spontaneous reduction. If not, you will have a big failure after repair. So don't repair capsulolabral defect under tension. It will fail. Every repair, it will fail under tension. For me, it is a cannula-free procedures because I have a lot of freedom without cannula to put for the direction of the anchor and all the instrument. So I don't use any cannula. Like we can see here, we have a lot of freedom without cannula. I mean, we have soft tissue, a lot of freedom. Here, I changed the anchor because the company in Lebanon, they don't provide, they provide us 2 ankle. So for me, I changed the angle and the length of the instrument to be adequate with the pathology. I mean, if we, I know I should grab the capsule, big grab, so I increase the lever arm. Final result, here, I put 3 to 4 double-loaded anchor anteriorly. If you have extensive, if I have a lapsa lesion and extensive Bankart lesion, it's not 2 anchor. For me, I put 8 stitches anteriorly. 8 stitches anteriorly. Don't forget, we have to put 3 to 4 anchor anteriorly in the anterior limb. I mean, it's not about the failure. It's about the technique. I mean, each patient has his way to do it. So I will not go through the technique. It is boring. Just to mention that when to do remplissage. I mean, we should do remplissage. Now remplissage is à la mode. We have to do remplissage for all our patients of anterior shoulder instability. Of course not. Not for all our patients. I mean, here remplissage, it's to fill in French. In French, it is basically a French procedures, and North American surgeons, they just popularize this technique, but it's at the beginning a French procedure. So it is popularized after the concept of off-track technique. Off-track technique mean an external rotation and abduction. When we have a big Hill-Sachs lesion, we may have engagement of this defect, a humeral defect, into the anterior and inferior glenoid rim. This is the off-track concept and on-track. On-track, I mean the direction, the size of the humeral defect, it's not so big to be engaged. So what is the concept of remplissage? Why they are doing remplissage? It's not like we do a posterior capsulodesis. The idea of remplissage from the beginning, it's to keep the defect extra-articular. That's it. It's not to create a posterior force or to do posterior subluxation. It's just to fill the defect. And when we are doing external rotation and abduction, we keep the defect extra-articular and we don't have engagement. Because they think the concept of off-track, we have dislocation because we have engagement. If we put just the capsule into the defect, we make the defect extra-articular. That's it. Okay? Here the Hill-Sachs lesion. I mean, for me here, I will show, we are coming up with a study to show that the size of his lesion and the concept of on and off track technique, it's not the only risk for dislocation. I mean, for a lot of my patients, I do posterior capsulodesis. Posterior capsulodesis for people does not have any Hill-Sachs lesion, but they do engagement without Hill-Sachs lesion because they have a huge laxity. And I confirmed by arthroscopy, when I'm doing arthroscopy, I do abduction and external rotation. Those patients does not have any glenoid defect or any humeral defect, but they do have engagement, I mean, off track, because they have a huge laxity. So we are publishing this for this reason. This is, for example, patient, he does not, I mean, it is not a huge, Hill-Sachs lesion, and he does not have any glenoid defect. For this reason, for this patient, I do a huge capsulodesis from posterior because at the physical examination, pre-op, he has multi-directional laxity, and he does have engagement without any bony defect. So I have a lot of patients like this, so I go posteriorly. I do do debridement under bleeding bone, and I just stick 2 anchors, 5.5 millimeter, triple loaded, and I do what I call posterior capsulodesis. I do it from the humeral side, and it's very effective. The only problem with this is at the beginning, we may have some limitation of rotation. It's expected, but I mean, most of them they do recover after 6 months from surgery. After 6 months, we have to keep physical therapy. The only problem, I think, is the stiffness. Here, for example, after doing the repair, it's a 3 anchor from anterior, double loaded, 2 anchor triple loaded from posterior, and the patient is excellent. I tie all of them from the subacromial spine. It's like rotator cuff tear. I feel it's a strong repair when I repair them directly under direct vision when I stick my scope into the subacromial space. Look, it's fantastic. It gives you a huge I mean, sense of power, let's say. Here, after remplissage, we have a lot of studies that say that the recurrence rate when are doing Bankart with remplissage, it is less than 2 to 1% recurrence rate. I mean, we have 5 to 10 years follow-up. A lot of studies. In peer-reviewed journals, this is American Journal of JBJS, Journal of Arthroscopy, North American of, I mean, it's very effective if you combine Bankart repair with remplissage, recurrence rate, remember, less than 2%. Here, the only problem with when you combine Bankart with remplissage, we have only problem is the limitation. We may have limitations. So, I mean, the success for this reason, we can say that the success of the surgery, it depends pre-op from the selection, from the surgeon, and post-op from the physical therapist. I mean, for this procedure, we need a trained physical therapy, a specialist physical therapy, like a specialist surgeon to do arthroscopy. We need a special physical therapy to know how to deal with this kind of surgery. Thank you very much.
Thank you, George, for those valuable tips and tricks. Is there any question? And after the question, we must go to the room A for the symposium. Muhammad.
We had a talk before about remplissage and the stiffness.
Yes,
because with a new technique, you can only depend on a capsular implication. They use only the capsular tissues to fill up the gap. And also maybe it's worth mentioning that knotted sutures at the subacromial space can increase the risk of a potential tear in the infraspinatus during physical therapy or later due to ischemia. So how you address those problems?
Yes, I mean there is a way to do it. I feel confident to do this technique. Maybe it's alternative technique. I'm stick doing this technique. I am comfortable with this. It gives me good results. I know maybe I will not mention maybe Artrex or other. They have the knotless technique. It is another way to do it, but I feel comfortable to do this technique. Really.
Very happy. I trust you.
Any other question? I have a concern actually. I'm doing those kind of surgery in the lateral position. And recently, since 6 months, I have a problem in decoaptation of this joint. I've tried almost everything, position, view, traction, to do it on the beach chair position.
Yeah.
Do you have the same problem
I mean,
of decoaptation when
yeah.
you're at
yes.
the level of the
Yes.
inferior part of the glenoid?
Yes. I mean,
how do you manage to have a decoaptation, to have enough space to
decoaptation, we have to do decoaptation as the Japanese said, zero. We have the zero position of the shoulder. When we have the shoulder, he is lax in all position. The Japanese colleague, they call it the zero position of the shoulder when the arm is in 30 to 40 degree or abduction. It is in forward 20 to 30 degree, and it's a neutral rotation. So this is a zero position of the shoulder. The shoulder is in complete laxity. Actually, I have my resident. I ask him in this position to push the shoulder lateral. I mean, to put his hand from the inner part of the, and to push the shoulder. And I have enough space doing this, actually.
I do agree with you because Dr. Shamsuddin raised this issue before about posterior subluxation of your joint when you do remplissage. I do think personally it's related when you do your knots. So usually I do leave it till the end. Once I'm finished and I have a centered head, then I tie my remplissage sutures. I pass them, then I tie them at the end. I think you do the same thing.
Yeah, of course.
So that's why I don't think
remplissage
puts your shoulder at the posterior position.
I do anterior translation during remplissage. And they have enough space, actually, enough space. Enough space.
So, answering your question, I do it in the lateral position also. I tried everything, as you said. The axillary roll, I tried.
Also tried this.
And I asked the anesthetist lower and distract the shoulder joint. But in the end, I came to the conclusion that the best thing is to have normal traction without any axillary roll. Just put the weight less. Usually I put 6 bags. I remove just one. I leave 3 kilograms. With a good relaxation from the anesthesiologist, you will be able to access.
Okay, thank you. We will close the session, and they are ready there. We'll go to room A. Thank you. And we'll come. There is a coffee break. We will come at 4:45.
يلا. So good afternoon. We'll start our session with Dr. Muhammad Nasruddin. Muhammad Nasruddin is a physician in AUB Medical Center. He has a lot of experience in shoulder, sports medicine, and arthroscopic surgery. And he will share us a lot of knowledge about partial subscapular tear. Thank you very much, Muhammad.
كتير طويل أنت هذا. Okay. So today we'll be talking about subscap tear, classification and treatments. So this will be the outline. So subscap is the primary anterior rotator of the shoulder. It's the strongest rotator cuff muscle. It's essential for shoulder stability, and it's the most powerful rotator cuff muscle, maintaining the anterior force couple of the shoulder. Basically, this was called the hidden lesion or the forgotten shoulder rotator cuff tear. So early open surgery used to miss it, especially when we're talking about partial articular surface. It was first described in 1834 by John Gregory Smith, and the major pioneer that introduced arthroscopy for subscap repair is Dr. Burkhardt. So before, we used to think that only 3.5% to 8%, roughly 5% of all our rotator cuff tears are subscap. But the new literature is describing more. Maybe now we are talking about 27% to 43% of all arthroscopic surgeries that we do, we encounter a subscap tear. Why? Why we're recognizing it more? Basically, enhancement of imaging, intra-articular arthroscopic identification, and improvement of surgical technique where subscap can be repaired. Why it's good to identify a subscap tear and repair it? Because in my humble experience and to my knowledge, it has the highest healing rate among all rotator cuff tears. And the retear rate is the lowest. Even partial healing of the subscap can maintain the balance in your shoulder and avoid arthropathy. As Dr. Rasi mentioned before, in the clinic is really where you plan your surgery. Sensitivity of the test combined is maybe higher than the MRI in case of subscap. With the belly press test correlating with the amount of the tear. You can injure your subscap by a forced external rotation with abduction, chronically with internal impingement, and iatrogenically mainly while doing a lateral jet. Radiologists miss up to 50% of subscap tear on MRI. Shoulder surgeons, because of the added value of the physical exam, are better. Detection improved with tear size as expected, and the clinical correlation and arthroscopic evaluation remain essential for accurate diagnosis. Why this low sensitivity of the MRI? Only 45%. Maybe because of the angles. MRI is not always good in detecting rotational, like the slap, like the subscap insertion, so they all miss. So the conventional MRI is only sensitive by 45%, but when it's there, it's there. You need to treat it. So that's why, with the help of AI, now we are creating radial sequence MRIs, which is increasing the sensitivity to 93%. Is yet to be implemented in the coming few years, so you increase your sensitivity in detecting those tears. It works like a wheel and spokes where even the smallest tear can be detected. This is a radial sequence MRI. On the right side, you can see thinning. On the left side, you can see full tear with retraction. So, till that time, we need to assess properly our imaging. If we have 2 out of 4 criteria, our sensitivity of detecting of subscap tear will increase to 75%. Biceps subluxation on MRI is a subscap tear. Also, the presence of or absence of the tear is important. So, if you have 2 criteria, then you have 75% detection rate. Evaluate for atrophy and evaluate for empty lesser tuberosity sign. Dr. Shamsuddin always, where is Dr. Shamsuddin? He's not here. Do we need a subscap? Do we always have a biceps subluxation in terms of subscap tear? It's associated. It's not always the case. Atrophy is more essential, and bare lesser tuberosity can be seen on sagittal views. Arthrography, if you're in doubt, and your doubt is based on your clinical exam, can increase the sensitivity to 94%. As we can see, biceps head is subluxed. There's no way of the biceps head to sublux medially without a subscap tear. Ultrasound, as a dynamic view, is more sensitive than the usual MRI. On the long axis, you have a pathognomonic bullet, and on the short axis, you have intratendinous tear. So, subscap tears detection during arthroscopy, which is the gold standard. Mainly, use the normal posterior portal, the anterior portal for working, and the lateral subacromial portal. Sometimes, in massive tear, LaFosse 3 and 4, you need to switch your camera to the lateral portal. And most importantly, you can use the anterior lateral portal for traction when your subscap is retracted. You can either use a 70-degree scope, which is not always the case in all hospitals, or you can simply forward flex 40 degrees, 40 plus 30 equals 70, then you can identify your subscap tear very well. So, forward deflection and mild internal rotation, the subscap insertion will be seen. Looking at the biceps will also give us clues arthroscopically. If we're seeing scuffing, abrasion, or tear, always check for your subscap. Most important pathognomonic anatomical arthroscopic finding is called the comma sign. The comma sign is a comma sign, as we can see, is formed by the superior glenohumeral ligament and the coracohumeral ligament, and it attaches on the anterolateral part of the subscap. It's very important in diagnosis, and it's very important in guiding the treatment because it keeps on being mobile. For example, here, this is the asterisk depicting a comma structure. In subscap tear, it changes from horizontal to vertical. And this is arthroscopically. When you have it, you can retract it, and you see your anatomic landmark. It helps you detecting the anatomic landmark. That's because usually, why it's important to detect the anatomic landmark? Because subscap tear are known to cause stiffness. So you need to release, and attach it to its anatomic landmark. So this is the lever test, which is important. As we said, push the shoulder posteriorly, then you can see your subscap tear. So this is the difference. When I do a lever test, you can see the extent of your tear. You see? So still we have the basic classification for subscap is LaFosse. La fosse, you need to know also that the upper 2/3 of the subscap is the tendinous part, and the lower 1/3 is only muscular. So 1, 2, 3, you can still manage intra-articularly, or we call it inbox. When we go to a higher La fosse changes like 4 and 5, 5, maybe it's better to do a tendon transfer. For 4, you need an accessory anterolateral porter to visualize well, and you need retraction sutures. Type 1 and 2, usually one anchor is efficient. Type 3, you need 2 anchors. Here comes a role of double row fixation. Type 4 also, when the fat infiltration is less than third, is the grade 1 to 3 Gottelier, you can reattach it with a good clinical result. The soft code group even mentioned, even with type 5, where fat infiltration more than grade 3, subscap reattachment was very helpful. Maybe because it will decrease the amount of progression for arthritis, because as we all know, arthritis is anterior and superior migration. Surgical management, indications: painful shoulder with full thickness subscap tear, partial thickness tear unresponsive to conservative treatment. It's a contraindicated to operate on a pain-free shoulder, regardless of the MRI finding. This cannot be stressed more. Grade 4 Gottelier is a contraindication still, arthropathy, infection, and non-compliant patient. Chronic subscap tear will retract medially more than posterior superior cuff tears. The tendon is usually mobile, so even if it's retracted, that's the nice thing about subscap. Even if it's at the glenoid level, you can get it back because you can work on the release from articular and extra-articular. Repairing the subscap will aid in posterior cuff repair and reduces overall tension. As Dr. Rossi said, the key for successful repair is a tension-free repair. Incomplete release will do persistent tendon retraction and suboptimal healing. That's why they fail. Complete release is the key success point. Studies have shown, and if complete release was done, a better tendon healing rate on MRI, improved functional scores, and reduced re-tear and stiffness. You can see this image. Who can expect a subscap tear here? Full adhesive capsulitis figure. Then, when you do your releases intra-articularly and extra-articularly, even on the subcoracoid space, sometimes we need to go and release the brachial plexus. Not in this case. Here you need to be very cautious about the axillary nerve and the two nerves we call the subscapular nerves, upper and lower, while doing the release. You need to see them. This is the difference between a before release and after release. The subscap, I think the key element of this presentation is to focus on the importance of releasing in subscap repairs. Knotted versus knotless. I'm a fan of knotless because I do believe that knotless will do even tensioning, but knotted can do better compression. So it depends on your philosophy. Even knotless sutures theoretically will cause less ischemia and lower operative time, but you can do both. Even that was studied, and both knotted and knotless single anchor repair are equally effective after 2 years. The addition of the lasso made a big difference because I find that when we are repairing the subscap tear, if you are using the conventional bird beak, you are creating a bigger hole. The lasso will provide you with a closer to anatomic landmark fixation and a smaller hole where your tape can be passed without losing it. Always think of supporting your repair by the biceps tenodesis. For massive tear, do not depend on one, on one anchor for both. You will need biceps on a single anchor and subscap on another anchor. Okay? You can use your biceps anchor for double row fixation because like the swivel lock, you'll end up with an extra line. So this is your tear after repair. It needs to be mobile you need to do the lever test again, and you need to avoid stiffness. This is when you are dealing with LaFosse 3 and 4, it's here, it's very important that you tag your superior lateral edge, you track it, and then with the scorpion needle, you will be able to reach down. Such a tear will need 2 anchors. When you're dealing with the partial articular surface tear, 1 anchor is enough, and you need to pass, it's recommended to pass it crisscross. For the fiber link is the blue one and the tape. And this was also studied with good evidence that combined subscapularis repair and biceps tenodesis using a double-loaded single anchor leads to a favorable outcome, with more than 90% of people reaching good functional and pain scores. Do we need to do coracoplasty and subscap repair? It will create more space. Were we able to support that by literature? Till now, not. But usually, it's an easy procedure. I do it routinely because I know for supraspinatus, when we do subacromial decompression, the re-tear rate will decrease. So I do expect that this applies also for subscap. Subscapularis repair in the setting of associated cuff tears, tons of studies, good functional outcomes. Severity of the belly press test correlated with the tear severity. So in your clinical note, like just as a practice for the residents, just mention the belly press test because it's also a clinical marker for improvement after surgery. So we're gonna share a few small video. This is a 36-year-old male, trauma, came around 2.5 months after the trauma. This is LaFosse 4. And I'm looking through the anterolateral portal. I'm putting a traction suture. I did the proper release. As you can see here, it's all red. This was all beyond the glenoid. With the proper releases, you end up with a tension-free repair. Okay. This is a patient at 6 weeks. They do well, they do amazing. Subscap repair never failed me. And this is at 12 weeks. Full range of motion. I really can't tell which hand is stronger. Even rehabilitation goal is to protect your repair. Always depend on your range of motion before progressing to strengthening. It's important here to mention that abduction brace is a must in subscap repairs because you need your elbow to be forward flexed and return to sport never before 4 months for rotator cuffs. Take home message. The incidence is rising because we are able to identify it better. Good outcomes. Healing is amazing. So why not? Exam matters. Physical exam is still crucial since imaging is still uncertain. Thank you.
Thank you, Muhammad. Any question from the audience? I have a question for you. Technically, when we are using a 30-degree scope from the posterior approach, and you do examination and you suspect a subscapular region, do onto a superior approach to repair it, or sometimes you what technique?
When I started, I used to switch to 70 degree. Now, just with the forward flexion to 30 to 40
to
degrees.
elevate the arm.
To
It's
elevate
enough.
the arm, basically, you're using a 70-degree scope.
You resect the middle glenohumeral ligament?
Not in all cases. I might resect it by the end, but I use it primarily to know the landmark. and to see
Yeah.
how much release is there.
You mean according to the size of the
Yes,
lesion and
exactly,
to the, okay.
Exactly. It's good to release it mainly if you're doing like upper 1/3, like Lafos 1
Okay.
or 2, because you'll avoid stiffness later on to build up.
Okay. So we know it is a hidden lesion. I mean, if we look for it, most of the time we search it because you are doing and I am doing arthroscopy. It's quite a common.
It's 45% of all arthroscopy is there, like, and maybe later on we can expect more. Its role in a frozen shoulder and things like that, because you're
Yeah.
developing stiffness.
And what you are doing with your biceps?
But always stenodesis.
Always
or tenotomy.
stenodesis.
No way to repair a subscap and leave the bicep.
Okay, good to know.
Muhammad, I have this impression. I don't know if George and you have the same impression. Usually I wait a lot for supraspinatus tear. And I told them, do physiotherapy and we will see later for the operation. But I have this impression for subscapularis tear, they retract too much. And I think we should do the operation early.
As soon
and
as
not
possible.
to wait for complete retraction. That's what you said also.
Yeah.
Have to release a lot, even go through
to the brachial
until
plexus.
the nerve
Yeah.
in order to retrieve the tendon from its.
It's good you mentioned that, especially in elderly. I face that because I know I can get subscap. You can always get it if you do proper releases. But would you risk an axillary nerve in a 60-year-old where there is a mild arthritis? In those cases, I won't go heroic. In a younger patient, I would go get it from beyond the glenoid. It's nice because it's, I think, the only tendon where you can work interarticular, extra-articular.
10 years ago or 5 years ago, we heard a lot about inside the box, outside the box.
Yeah.
Actually, like George said, you're working inside the joint from posterior. You're not comfortable.
Exactly. That's it. Because they like those nomenclature for papers. But literally, we are doing that without naming that. Thank you.
Thank you, Muhammad.
Now, we will continue with Dr. George Rassi. How to optimize rotator cuff arthroscopy.
Thank you, Rami. Thank you, Muhammad. Very nice presentation. Actually, I mean, let's understand what is the role of rotator cuff repair and what is the goal of surgery. Actually, he's a group of patients, Lebanese patients, coming to my clinic. All of them, they have the same diagnosis. They have full thickness rotator cuff tear. But each of them, they have expectation from surgery. I mean, they have different demographic data, and they have different needs after surgery. And they are coming from different symptoms. They are different patients with the same diagnosis. I mean, it is make sense to offer for them the same surgery? Of course not. I mean, it's a la carte surgery. I mean, there is some of them come for pain, other come from function, and they need different treatment. Here, he's one of my patient. He's 3 months after doing rotator cuff repair, and he is going back to boxing. I mean, how we can do this? How we can offer for him the technique to do this? Rotator cuff repair, it's not just to stick the scope and the scorpion needle and to repair it at any price. Rotator cuff repair, we should have anatomical repair. It is like when you are doing, a distal humeral fracture, intra-articular fracture. We have to have anatomical fixation, and we have to have a strong fixation. So rotator cuff repair, we should store the anatomy. If not, you will have a big problem with physical therapy, and after it may fail. So the goal is here, it's not to repair the rotator cuff at any price. We have to have an anatomical repair. We have to restore the biomechanics. It's like fracture. We have to have a strong fixation and to promote healing. A lot of way to repair the rotator cuff. Here, in the Journal of Arthroscopy, it is a very nice article that says that the single row, we have the ultimate tensile strength. What is the ultimate tensile strength? I mean, when we repair the rotator cuff, when we have tension on the rotator cuff, at what degree it may fail. When we do a single row, it fails at 250 Newton. Double row at almost 300. And a transosseous technique, I mean a suture bridge, it failed at 400. What does that mean? That means during rotation, the double row fixation, it's more solid. And after repair, we can allow, if we are doing a double row technique, a rotation before 3 weeks. So this is biomechanics. But in clinical, 3 of them, they have the same clinical results after 6 months. I mean, which technique we should use? I mean, it's a dilemma. Here we go. Go to the literature. No difference. No difference clinical results between the 3 techniques. Again and again. Double row technique, it's more efficient biomechanic, but clinical results, again, is the same. What about suture bridge? It's more important during rotation and it's more stable, but clinical results, it is the same. So here it's big meta-analysis that shows that, I mean, it's a dilemma. They have most of the time the same clinical results. Double row is better than single row for all size and during all conditions. So what to do? Here a very nice study that show that, I mean, we should look for the remnant of the rotator cuff. If we have the tendinous part here, it is less than 1 centimeter, we cannot do double row technique. And most of the time, if we have massive tear, full thickness rotator cuff tear, and the tendinous part is less than 1 centimeter, we cannot do the anterograde technique, because when we put the scorpion needle here, it will go between the muscle and tendinous part, and it will fail with time. For this reason, we have failure. And for this reason, if you have the tendinous part, it is very short, we have to do the anterograde technique. I mean, coming from here, from the muscle part, and end with the tendinous part to prevent failure. Because when we are using scorpion needle, the scorpion, it will go through the most weakest part. It will go here, and will have failure. Believe me, we'll have failure. So we cannot do double row technique for all configuration of rotator cuff tear. Here a study that said that yes, of course, when we have the medial stitch is near the muscular tendinous junction, will have failure. When it is away from at least 1 centimeter from the muscular tendinous junction, we'll have success of surgery. So be careful. I mean, rotator cuff tear, it's not for anybody to do it. For this reason, we have a lot of failure. It's not because of the technique, it is because of the surgeon. Here, single row and double row, it's better. It's better for rotation stability, of course. What about the cost? I mean, in Lebanon, we have an economical crisis, and we have the insurance company, and you know, the healthcare system, sometimes you cannot afford double row technique. I mean, double row technique, it's maybe $2,000. It's expensive than single row. I mean, why we go to a procedures when we can do, for example, 3 rotator cuff tear, at least we do 1 rotator cuff tear with split bridge technique. I mean, we have to take it in consideration. So what we should learn from this, irrespective to the type of surgical treatment, open, scope, single row, double row, rotator cuff results, it is reliable to relieve pain and function. It is a good surgery. I mean, if we know how to do it, rotator cuff repair, it's a good surgery and it can give excellent results. So double row may be better than single row, We don't have statistically or clinically for long-term result, but it's better to early range of motion and to early results during physical therapy. Success is multifactorial. It depends from the compliance of patient and from the skills of the surgeon. So single row, the surgeon, he should not make systematically single row or double row. He should individualize. He should do the technique a la carte. He should select his patient for single row, for double row, and for transosseous technique. Split bridge, a lot of advantage. It decrease suture cut through because we don't have any stitch at the medial row. So it improves vascular inflow. We don't have a lot of tension, less irritation because we don't have this, and it's better biology. So what about triple row technique? Triple row technique. He is one of our patient. He's young, 22 years old. He has fresh rotator cuff tear. He is athletes involved high-level sports activity. He has as I said, fresh. So I went with triple row technique. He has a footprint more than 1.5 or 6 centimeters. So it's huge. I cannot offer for him a single row technique. I cannot offer for him a split bridge because he's young. It's too much, I think, for him. So I offer for him a triple loaded approach. Triple loaded, it's excellent, believe me, to cover and all the footprint. Here we go. Just we use the biceps also for the defect to reinforce the repair, and just we stick to 3 triple loaded anchor at the junction of the cartilage and bone. The second row, as we can see here, after at the tip of the greater tuberosity, to create an anatomical repair of the rotator cuff. He's young, so we need anatomical repair of the rotator cuff. And this is the only way to have anatomical repair of the rotator cuff if we have a big footprint, if we have excellent length of the tendinous part of the rotator cuff. So we just pass the stitch medially. We take them away, and we put the anchor at the tip here, as you can see here, at the tip of the greater tuberosity, to have anatomical reduction, better application, and the third row on the lateral aspect of the greater tuberosity. So this is triple loaded technique. The triple load, it maximizes the footprint contact, as we said, expose the tendon more to the bone for better healing, improve healing potential. So what to do? What to do? Actually, he is for example, one of our patients. He has a massive rotator cuff tear. The tendinous length is about 6 millimeter, single row. He has another patient. He has the same age, same needs, everything. He has big tendinous part. So we go to a suture bridge technique. Here what we do for our patient for a speed bridge technique we published in the Journal of Arthroscopy. So we modified the technique unless we have one penetration here, proximal, we make two for better application, and we use biceps for to gap for the defect anteriorly to reinforce the repair of the rotator cuff. Okay, and we have good result with this. With summary, speed bridge, it's excellent. I mean, if we have the financial clearance, speed bridge, it's excellent technique. It is difficult, challenging technically, but it's excellent technique. We can start easy physical therapy. I mean, if we have good footprint, a big tendinous length, young patient, needs early recovery, go directly to speed bridge technique. Single row technique should be reserved only for patients who have very, very small tear or a massive tear with the tendinous length less than 1 centimeter. Go to single row, it will give excellent results because we don't go to the junction of tendon and muscle. We are away 2-3 millimeter and just grab the tendon. If it is a small tendon, you go for single row. Double row, knotless repair, for most cuff tear, we can use it. If we have enough tendon and young patient. Thank you.
Thank you, George. Does anybody have a question in the audience? Muhammad.
Just a question about usage of the biceps to fill the gap. Pass
No, I use like superior capsular reconstruction with biceps. The proximal anchor, it's triple loaded. I use one of the stitch through the biceps to bring the biceps anteriorly, and then I put it under the rotator cuff. So I use double. I use the biceps to fill the defect, and I do superior capsular reconstruction with biceps.
That means you
This
don't
is our
do,
modified technique.
You don't do the tenotomy near the glenoid.
No,
You do the
I
tenotomy in
do
the
the
groove.
tenodesis like 6 to 7 millimeter posterior to the bicipital groove, not into the bicipital groove.
But no, you're not doing a tenotomy.
No.
If you want to use it as a capsular reconstruction,
Yeah.
you will leave it inserted over the glenoid, the biceps.
Yeah, you can do both of them. You can do both of them. You can do both of them. The idea is just to keep the biceps at the top of the greater tuberosity. I use stitch one anchor in the bicipital groove distally, one anchor I use for the anchor of the rotator cuff repair, the proximal anchor, and the third fixation I use with the scorpion needle with the rotator cuff. I mean soft tissue fixation. So triple loaded fixation.
Okay. No more questions? Thank you, George.
Ayman.
Ayman is not here.
Ayman is not here? Okay, I will proceed with the second, please. Massive rotator cuff tear.
You gave me the simplest part. Cut it.
The most difficult part,
No,
actually.
cut it and run, and do nothing. So I will speak about not biceps tenotomy, But about biceps tenodesis, does the location matter if we fix it at the level of suprapectoral or subpectoral? Does it matter in terms of functional result, in terms of pain? Why are we doing biceps tenotomy and tenodesis? It's because there is pathology at this level, and we are trying to relieve pain and to improve the function. What are those pathologies? There are inflammation, event or phenomena at the level of the biceps. There are fraying, there are partial tears, there are complete tears. Complete tear, it's a solution. It will be cut and it will relieve the pain. And we find also there is instability of this biceps concomitant with or without supraspinatus subscapularis tear. All of those lesions of the biceps are found in the context of shoulder impingement or associated with rotator cuff tear or a slap problem, slap tear. There is a classification, this is the classification of Kim, of those pathologies of the biceps. It's 5 types. Type 1, it's normal. Type 2, it's an hourglass deformity. Pointer. Type 3, it's a fraying less than 50% and outside the groove. It's not reaching inside the groove. Type 4, it's more than 50% and reaching the groove. And type 5, it's a complete tear. It's the solution. And when we cut this biceps at the level of the glenoid, it will reach how far from this glenoid? Will it stuck in the groove or will it go beyond the groove? We've done a study tagging those biceps. We have tenotomized and with a ProTag, and we have done X-rays on day 1 post-op, 1 month and 3 months. And we have measured the degree of retraction following this tag at 1 day, 1 month and 3 months. And we found out that it will reach at day 1, 1.9 centimeter from the glenoid, and at 3 months it will reach 3.5 centimeter from the glenoid. And we found out that those long head of the biceps will retract beyond the transverse. Tenotomy, we won't have a bicep stuck inside the groove that will cause maybe a pain. And we found out that there are more retraction in patients with positive Papai sign and less retraction in the rotator cuff repair group, maybe because we are immobilizing them for a long period, around 6 weeks, and we are postponing the physiotherapy. The treatment of those problems of the biceps could be tenotomy alone or tenotomy with tenodesis. Don't be surprised, this is a randomized control study, 2025. This randomized study shows that releasing a normal biceps tendon at the same time of a cuff repair improves patient outcome and decreased reoperation. While repairing this cuff, sometimes we find that the biceps is normal. Don't hesitate to cut it because you will have better result on the pain and less reoperation. And when we cut it and we have to do a tenotomy, tenodesis, it could be at the edge, it means at the entrance of the groove. It could be done arthroscopically and it is intra-articular. It could be done at the level of zone 1, zone 2. It's the suprapectoral zone. It could be done arthroscopically. And in the subpectoral zone, it is done open. Yani we do the tenotomy arthroscopically, and we have to do, you all know, a small incision in the axilla in order to do the subpectoral tenodesis. Attention,
this is the major concern. It should be your nightmare to not overtension the long head of the biceps. You will have a good tenodesis without a biceps Popeye sign. It's aesthetic, it's good, but the patient suffers a lot from contraction, muscle contraction, and muscle tension. To do so, you should keep in mind that this musculo-tendinous junction should remains at the same place after the fixing the biceps. That's why we must take into consideration the depth of the tunnel, I mean the length of the interference screw if you are using an interference screw. In order to calculate the length of the tendon, you will keep inside this tunnel not to overtension the biceps muscle and bringing the musculotendinous junction proximally. And also, while doing the suprapectoral, subpectoral tenodesis, you must respect this position of the musculotendinous junction. And always keep in mind that the musculotendinous junction, this is it, it's around 3 centimeters from the distal edge of the pectoralis major and 2 centimeters from the superior edge of the pectoralis major. It should stay at this place. You should not overtension, and always keep in mind the position of the cutaneous nerve. It's about 1 centimeter medial to this musculotendinous junction. So, what to choose? Suprapectoral, subpectoral. In this cadaveric study, they have studied suprapectoral and subpectoral tenodesis, and by putting a marker in the musculotendinous joint and junction, and as you can see on the right side, we have the tendency to overtension. Thus, the marker has shifted proximally after tenodesis, and this tendency is more while we are doing suprapectoral biceps tenodesis. In subpectoral, we have less tendency to put less tension, maybe because we are seeing the muscle junctional, the muscle tendinous junction, we are seeing it. It's not arthroscopically. And we have several kinds of fixation. Fixation could be onlay, inlay, and fixation with an interference screw, fixation with undo button, fixation with suture anchor. Those kind of fixation are almost all the same. If you use the inlay or the onlay subpectoral or suprapectoral tenodesis, it gave the same clinical result and the same healing rate using ultrasound assessment to assess the healing of this tenodesis. And this meta-analysis showed that it doesn't matter if you do it inlay or onlay, it has given the same clinical result approximatively with low risk of Popeye sign in onlay or inlay tenodesis. And biceps tenodesis, supra or subpectoral, chronologically, I have reviewed all those articles comparing those two techniques from 2020 till 2025. And in this review and systematic review and meta-analysis, they found out that suprapectoral or subpectoral biceps tenodesis gave the same clinical outcome, same complication rates, same residual pain, same Popeye sign. It doesn't matter. You have to choose between which one you are more comfortable. But in this systematic review, even there is no difference between outcome and failure, they found out that suprapectoral tenodesis gives more stiffness, while subpectoral tenodesis afford better range of motion. And in this also review and systematic review, they found out that we have also similar clinical outcome, but in suprapectoral tenodesis, we have more persistent pain, more failure, and more Popeye sign, while in subpectoral tenodesis, we have more transient nerve injury. I showed you the anatomical photo. The nerve is there. Maybe you're putting a Farabeuf and putting a lot of tension over it, but they describe transient nerve injury in subpectoral tenodesis. And this randomized control study comparing arthroscopic suprapectoral biceps tenodesis to open subpectoral biceps tenodesis, they found out no statistical difference between those two groups in clinical outcome and clinical scores. And also in this systematic review from 2025, they have included 13 studies. They found out a higher complication rate in suprapectoral tenodesis. And also this one, comparable functional outcome, it's almost the same result, higher complication rate in suprapectoral tenodesis, but longer surgical time also for suprapectoral tenodesis. What are the complications that we must encounter while doing those tenodesis? First of all, and the most dangerous one, is to have a fracture of the humerus, mainly in subpectoral tenodesis and mainly while you are using an interference screw. So don't use more than 8 millimeter interference screw. You will have to do the hole and put the screw. You're creating fragility over the medial or mediolateral, medio-anterior cortex. The most important thing is to not overtension the long head of the biceps, because it will cause a lot of cramping and a lot of pain. And we are keen to do this in suprapectoral tenodesis. There is a persistent pain in the level of the bicipital groove if we do an intra-articular biceps tenodesis. We didn't spoke about this. And loss of fixation, sometimes you fix it, the fixation will be loose, and we will have Popeye sign. And always think about the musculocutaneous nerve in subpectoralis tenodesis in order not to have a nerve problem. So as a conclusion, the first conclusion, while we do an over-the-edge intra-articular biceps tenodesis, we can do it arthroscopically. There is a minimal risk of tensioning because we are seeing the tendon and we are cutting it far medially and bringing it laterally, fixing it at the entrance of the groove. There will be no tension over the muscle. The biceps is still in the groove. Maybe we can have pain caused of inflammation in the groove. In suprapectoral tenodesis, we could do this arthroscopically, but there is a severe risk of overtensioning. In subpectoral, it's open, and there is moderate risk of overtensioning. Thus, as a conclusion, suprapectoral, subpectoral, same functional outcome. In suprapectoral, we have more minor complications, more stiffness, more failure, more Popeye sign, more muscle tension, while in subpectoral, it's almost the same functional outcome, but we have more transient nerve injuries. And at the end, suprapectoral and subpectoral tenodesis are both effective when performed correctly. Do not overtension, do a good fixation, and there was no significant outcome difference between those two techniques.
Thank you, Rami.
Tenotomy and
Be safe.
ريح راسك.
Thank you, Rami. Any question? Ahmed.
Completion. Even the groove pain, even if you get a tight you lose movement of your biceps in the groove. So even running that risk still for me is better than going and have a neuropraxia and less time. For also.
Usually when we do tenodesis and tenotomy, we have cramping on the biceps muscle. And we always say to the patient, it will last for 6 months and things will get better. Frankly speaking, from the last 5 years, I have done 6 detenotomy. I have detenotomized bicepses. Previously, they have done tenodesis because of persistent pain. And all the patient did well. But I have done this after not 6 months, after 2 years or 3 years. Sometimes the cramp persists for several years.
Another question, please.
Thank you, Rami, for this excellent presentation. My first question is, sometimes during our surgeries, we found that we have a very severe tendinitis of the biceps, and you want to do tenodesis, and you are in front of a case, let's say 60 years old, and this is tricky to go for tenodesis with a bad quality of tendon, and you have the theory that tenotomy will be best. So what is your experience in this case?
You mean in tendinitis, not in partial tear or subluxation?
Exactly.
It's
Severe
special,
tendinitis.
severe tendinitis.
60-year-old with a problem of a cuff repair,
Yes.
or
Yes,
fraying, or
no, cuff repair, and we found this.
I personally do tenotomy.
Dr. Rassi, what you?
No, I mean, I will do tenotomy if the patient, always I do tenotomy in cuff repair. If the patient, he does not, care about cosmetic deformity. I fully agree with Rami, tenotomy is better than tenodesis. Tenodesis, I have a lot of anterior shoulder pain after tenodesis. I mean, in the clinic, sometimes I use the ultrasound and number 11 blade to cut the tendon.
You want to cut it?
I want to cut the tendon. I mean, tenodesis, it's hell sometimes.
I've did it twice under ultrasound with the radiologist.
It's,
with
I
a
mean,
needle, I
tenodesis,
cut the tendon.
My second question is, I have a case, sorry.
And even after this randomized control study, even if the biceps is good, while you're doing cuff
tenotomy.
repair, do not hesitate and do not blame yourself
If you do tenotomy.
It will give better result. I don't only preserve the tenodesis for high-level athletes, young, caring about their shape.
Okay.
Don't listen fully to Rami. Rami, he's a biceps killer, huh?
And my second question is about Popeye sign, because I have one patient that always he told me the problem is his. What is the solution that we can offer to our patient in this particular case? When we do tenotomy, I have one patient always in my clinic saying the shape is
no. Maybe you should prevent them or inform them before the operation.
Already,
I used to do this, and they come back always to ask me, look, I have this one. The day I stop telling them that you will have a Popeye sign, nobody from those patients are
complaining of
this.
I will give you a solution. You tell the patient. Sorry.
I don't have high-level sports patients. Usually, they have sufficient fat tissue that will cover this Popeye sign. or papai deformity?
I mean, you have to remember that papai deformity, it's acute. It's acute. It's not chronic. I mean, after 1 year, you have atrophy of the muscles. You don't have any papai sign. After 1 year, you have complete atrophy. So there, the patient, it is temporary. After 1 year, you will have nothing. It's similar. It's good. It's okay.
في study اسمها papai sign is a doctor problem. It means they didn't inform the patient. They send the patient for whom they did tenotomy to 2 doctors to examine them. The patient didn't discover the sign over himself. Only doctors discover this. But you look for it, you will find it. You neglect it, يمكن they will not find it, the patients.
Okay. Any other question? Okay, thank you. So we'll proceed with the last topic. It's how to deal with massive rotator cuff tear. So here are 2 patients. Both of them, they have massive rotator cuff tear. Both of them, they have the drop arm sign. I mean, it is a fully massive rotator cuff tear. They have different patient, different needs, one diagnosis, massive rotator cuff tear. So what to do? We have different option. I mean, it depends on the age, need, function, activity, comorbidities, symptoms. We have different option. We don't have only one solution to massive rotator cuff tear. We may have conservative treatment, debridement, partial repair, tendinous transfer, balance spacer, superior capsular reconstruction, and reverse shoulder arthroplasty. So for the same diagnosis, we have different options. What to choose? I mean, what option we should choose in case of rotator cuff, massive rotator cuff tear? We have to think not about us. It's not up to the surgeon to decide. It's for the patient to share idea. I mean, because the treatment is depend on the patient need and satisfaction, and we have to look for patient expectation. I mean, for elderly patient, pseudoparalysis with rotator cuff arthropathy, only reverse shoulder prosthesis. Elderly, low demand, severe pain, we have to do debridement because patient is coming for pain. I mean, young patient, always try partial repair during, even partial repair. If complete repair it's not successful, we should at least try partial repair or tendinous transfer or superior capsular reconstruction. I mean, it is a dilemma. It depends on many factors what to do in massive rotator cuff tear. How long we should wait? I mean, in acute pseudoparalysis, young patient, high expectation, 30 years coming for massive rotator cuff tear. Why wait? Do it urgently. If it is traumatic, why wait? We should not wait. And the chronic patient, we should wait 3 months maybe. I mean, I will ask the patient, if the patient is coming to me for massive rotator cuff tear, I will not wait. If the patient, he has high expectation and high needs, why wait? I mean, wait for fatty atrophy? Why wait? Here, for example, massive rotator cuff tear. One of my patients, she is coming for massive rotator cuff tear. She has dull pain, minimal pain. Doing the X-ray, she has anterior and superior subluxation. She has osteophyte lateral, but she has full function with minimal pain. I mean, why you are coming? Because I have dull pain at night. Okay, conservative treatment. She will not. She does not have. I mean, results is better than reverse shoulder arthroplasty. Okay, I cannot give her better results. So let her enjoy the shoulder with osteoarthritis. Here, arthroscopic debridement, 600 patients, arthroscopic debridement for massive rotator cuff tear, need a lot of experience, a lot of skills. It's not for any surgeon to do it. Here, one of my patients with massive rotator cuff tear, I mean, we have to do minimal acromoplasty. Don't resect the coracoacromial ligament. Bicep stenotomy, debridement, we have to spare the AC joint. I mean, we are going to do debridement for massive rotator cuff tear and we end up with reverse shoulder prosthesis. Don't do it. Don't do it. It's just do debridement with bicep stenotomy with minimal acromoplasty. It's like capping the acromion. It's not resecting the acromion. So coracoacromial ligament, a lot of report. Coracoacromial ligament release, a huge acromoplasty. In massive rotator cuff tear, that means we are going toward reverse shoulder prosthesis. It is the second surgery. Believe me, it is the second surgery. So good mobility, good bone stock. We have to, I mean, this is one of the patient. She is 35 years. She is the wife of orthopedic surgeon, colleague of us. So he told me, George, we don't want to do a reverse shoulder prosthesis for my wife. This is she's right-handed. We can try to do anything. So he was with me in the surgery. We did look the rotator cuff tear. I resect here the everything. I resect the superior labrum to give more space, good mobility, good, and we did a medial repair, of course, because we have a huge retraction. 30 years we did a medial repair, and we were able to look, because she's also very osteoporotic, a lot of disuse osteoporosis. It was very difficult surgery, so we achieved to do a full thickness repair of the rotator cuff. So debridement, release, and massive rotator cuff tear, it is a huge part from the surgery. If we are going to surgery just to grab the rotator cuff and try to repair it, it will not work. It will not work. Look the repair. But it will take 3 hours. I mean, 1 hour and a half just to do release. I mean, look the repair. It's excellent. Here, second one also, he has a bone stock. It is a revision. It is second case of very, very massive rotator cuff tear, and we can achieve reduction as well. So be careful that release, it's a good part from surgery. I mean, look, reverse shoulder prosthesis. He is one of our colleague, orthopedic surgeon. He's orthopedic surgeon, 59 years, and he don't want prosthesis. He told me, try to do partial repair, debridement, bicep, but don't do for me that. She's a wife orthopedic surgeon, he's an orthopedic surgeon. So in both cases, because I was patient in surgery, I mean, I took a lot of time to do the repair because they mean for me. And so I achieved to do full thickness rotator cuff tear and massive. I mean, if they are not, maybe I will go to reverse shoulder. So we can achieve a full thickness rotator cuff. Here in the Journal of Arthroscopy, our Korean colleagues, they say even partial rotator cuff tear, as used by Burkhardt, they have a big series of patients. So they call it suspension bridge. What do you mean the suspension bridge? They take the distal and the proximal part from the tendinous part of the rotator cuff. They fix it to the humeral. They think it works. It works because it prevents ascension of the humeral head. So even if we can achieve to do not full thickness rotator cuff repair, partial rotator cuff repair, it's better than doing nothing. It's better than prosthesis or balloon spacer or everything, believe me. Here at our institution, when we have massive rotator cuff tear, we do a single approach. We don't even cut or do a middle approach because of the deltoid. I mean, when we have massive rotator cuff tear, we have the deltoid is the only muscle who is working. So we don't touch the deltoid. We do all our repair, even if we put 4 anchors through one portal, anterior portal. We call it the anterosapperolateral portal. Another option, latissimus transfer. All of us do latissimus transfer. All of shoulder surgeon, we know we do it at least once, but it requires intact subscapularis. Also, we have another problem. It's the inability to this muscle to center the head. Inability of the deltoid to regain the pre-existing strength. So we have eccentric force always. A transposition never lead to a normal function of the shoulder. Tendon transposition, he is our compatriot, Dr. Basim Al-Hassan. He is doing his famous surgery. He's very known surgeon, Dr. Hassan, Basim Al-Hassan. He is doing arthroscopic lower trapezius transfer. He said he's doing a lot of publication in his hand. It works very well. It's alternative to latissimus dorsi. So in this surgery, we have a good vector. He used in case of non-repairable rotator cuff tear, torn infraspinatus muscles, but allograft, we don't have allograft in Lebanon. He used Achilles tendon allograft. It's not available in Lebanon, Achilles tendon allograft. So here is also Joseph Aboud. All of them are Lebanese compatriots who invented all those techniques. Joseph Aboud, he is doing a spacer. He settled down in Philadelphia. He used the technique of spacer in case of massive rotator cuff tear, and he says he mentioned good result on doing this. I don't know. I don't have the superior capsular reconstruction with biceps. It need intact and functional subscapularis. Most of those technique, palliative technique, they need a good subscapularis muscles. Don't forget, good subscapularis muscles. Superior capsular reconstruction is a technique from Artex. It preserves the joint, provide a superior restraint of the humeral head. To understand this technique, we will not go through all of them. What is the indication and what is the advantage and disadvantage? I mean, of latissimus dorsi, it's not anatomical procedures. We have a loss of donor function, a lot of variation in functional outcome. Here is a technique of Dr. Hassan. It needs allograft skills, a lot of infection because it's allograft nerve injury. Balloon arthroplasty, a lot of migration, deflation, infection. It's a foreign body, suboptimal results, and don't forget the cost. Superior capsular reconstruction, high failure rate, needs skill, no strength of external rotation, need good subscapularis. Most of them, they need good subscapularis muscle. Management, he's a patient. Don't forget, go directly to reverse shoulder prosthesis. It's a hell. Why? Because if we have failure, believe me, revision of reverse shoulder prosthesis, it's a hell. Almost we cannot do revision if the patient is osteoporotic. And Dr. Charles Neer, he said the most difficult surgery in all orthopedic surgery is revision of reverse shoulder arthroplasty. So be careful, don't do it from the first. I mean, it's maybe it can work like this patient, but it cannot work and will end up with the hell. So I said in our institution, for massive non-repairable, we combined the both technique, allograft with biceps, and do superior capsular reconstruction with allograft and with biceps, and we published in the Journal of Arthroscopy. Here, one of our patients, the result, it's like 1 year and a half. It's MRI. Look, after superior capsular reconstruction. Excellent. The capsule is here. The capsule is here. Here's the patient directly after surgery. And here's the patient at 1 year and a half. sending his video from Dubai. He's working at Dubai. He's like 65 years. He does not want any reverse shoulder prosthesis. So they offer for him reverse shoulder prosthesis. He sent me his video. Look, he's doing all kind of motion, all range of motion. It's pain-free, and he's playing box. Look, he's very happy. Okay, this is superior capsular reconstruction. It can be an excellent alternative in patients who don't want. So, don't go directly to reverse shoulder prosthesis in case of massive. We may have a lot of solution. What is the idea of superior capsular reconstruction? Don't forget the tendon, rotator cuff tear. We have here under the rotator cuff tear, we have a capsule. It's like 1 millimeter or 2 millimeter. What is the role of superior capsular reconstruction? If to recreate this capsule only, not the tendon. It's to prevent anterior and superior migration of the humeral head, and to keep the humeral head in anatomical position. If we try to keep the humeral head in anatomical position, we may have a range of motion without rotator. This is the bottom line. Here our technique, we modified. I will not go, you can see it on the net. It's excellent. So why go directly to reverse shoulder prosthesis actually, if we have option to do, in our cases, I am confident with superior capsular reconstruction with biceps. I do combination of both of them, and I have excellent result. I don't have a big number of patients, but I have enough number of patients to say I will continue with this technique. Here's a video. I will not go through all. So the conclusion is superior capsular reconstruction using the biceps combined technique. It's good option for non-repairable rotator cuff tear. It offers superior stability with decreased pain, preservation of the arch. It is important, and patient selection and careful technique are critical for achieving the best possible outcomes. So we have to choose our patient for the best technique. Okay, it's a la carte. Choose patient for technique. Thank you.
George, thank you for this nice presentation. You showed us 2 videos. One of the wife of an orthopedic surgeon.
Yeah.
This massive rotator cuff tear, when you're putting it lateral, fixing it on the tuberosity, medial side of the tuberosity, you're assessing before the fatty degeneration and the atrophy of the muscle.
Yeah.
Those muscles will not recover. They are not functional anymore. When you're putting them there, maybe they will act as a superior capsular reconstruction. Not as a real muscle, but it will not recover. The muscle will not recover its strength, and the fatty degeneration will not decrease.
Yeah. I agree with you. Even in rotator cuff tear, maybe even if we can achieve to reduce and fix in anatomical position the rotator cuff, if we have fatty atrophy, the function of the muscles, it will not, if we are doing a ACL reconstruction, we have fatty atrophy of the quadriceps. Patient coming after 3-4 years, severe atrophy of the quadriceps. They are never, if we have fatty atrophy, it is never reversible, never reversible. I fully agree with you that maybe it's not functional, it is act like superior capsular reconstruction. I think about this, but at the end of the day, I have a good clinical results. Good clinical results. So why not?
Is to maintain the head concentric. That's why even if you repair a fatty atrophied tendon and its an anatomical position, you will get a fulcrum for your deltoid to work nicely. So I guess the paper you discussed where you don't touch the deltoid is very important concept. So mainly concentricity is important because rotator cuff works only for the first few degrees and the deltoid will take over. You don't need it maybe to be as functional as we think it should be.
Approved by a publication of Collin in type 1, type A, B, C, D, or 1, 2, 3, 4. I
1,
don't
2,
remember.
3, 4 of
If we
Gottlieb.
have the inferior part of the subscapularis and the teres minor, it's more than enough. We don't have pseudoparalytic shoulder in those patients. It means that those two small muscles from anterior and posterior will afford the stability of the shoulder, and the deltoid will afford the mobility of the shoulder.
All of them, Rami, it's the same concept, same philosophy, same idea. The superior capsular reconstruction with biceps always. I mean, to translate the biceps to the greater tuberosity is to lower the liver arm. Even the osteophyte of the acromion with elderly people, we don't have to resect the osteophyte because it is lower the humeral head and it's kept into position.
يعني بسميها Gartzman smoothie arch. You don't have to resect nor the bone, a lot of bone, and mainly you mentioned it, it's a disaster if you cut the coracoacromial ligament. The head will move for subluxate anterior and superior.
Yeah. Yeah.
Thank you for this presentation. My question to you is, when you are doing a superior capsular reconstruction with biceps and allograft, you always, I saw that you don't touch the coracoacromial ligament because in theory, now the head is blocked because of the superior capsular reconstruction. So you don't touch it.
No, I don't touch. Because it is a primary restraint to subluxation of the humeral head.
Because already
I don't touch anything. I just the superior glenoid. I resect the labrum from the superior glenoid from 3 to 4 millimeter to make a good application of the allograft, and I use anchor for the biceps anteriorly. All of this technique is to lower the humeral head, to keep it into position.
So as I did understand,
you use it when you have superior migration at X-ray.